through these, but slide 4 you will see is the 6 national alignment principles. If people haven't seen them, do have a good look. Eleanor also sent out with the slides for today the document that gives more detail on these. And I think we kind of instigated this locally because as Medway was a demonstrator site and KSS, Kent, Surrey and Sussex were early implementers, and we recognised that whilst the two programmes can potentially dovetail really nicely, there's also potential for them to undermine on each other and cause confusion if that dovetailing isn't done quite carefully. So really that's what the rest of the webinar is going to be about. We haven't got all the answers. It's still early days for most areas, so hopefully in the Q&As people can share what they're doing and get a few ideas and possibly prompts to help us think through some of the issues that have come up during that implementation. So without further ado, if we can move on to slide 5, and I will hand over to Tori Lawrence from the Public Health team in Brighton.
Okay, can everybody hear me? Can you hear me?
Yep.
Yeah, okay, great. So I'm going to kick off with how basically we developed the diabetes prevention programme and aligned this with the NHS health checks in Brighton and Hove. So furthering Brighton and Hove being announced as one of the first tranche of the NHS diabetes prevention programme, a business case was developed with Public Health and the CCG to fund and roll out a citywide LCS for the diabetes prevention programme. If you can put it onto the next slide, please.
So that's slide 6 for those on the phone.
As part of the LCS, we created a process map to ensure the NHS health checks and national alignment principles that Nikki just referred to were an integral part of the process, and also to ensure that we had a consistent rollout of the programme across the city, which we actually rolled out on a cluster by cluster basis. So to deliver this LCS in Brighton and Hove, we set up a working group to deliver the rollout, and the group included the CCG Commissioner, myself from Public Health, Janet from Ingius, the Clinical Diabetes Lead also from the CCG, and the Practice Lead from the identified champion practice within the first cluster that we were rolling out in. And across the city, all the practices signed up to the LCS for the NHS Diabetes Prevention Programme, which, as you can see, aimed to provide a cluster-wide identification and referral service to the Diabetes Prevention Programme and other locally commissioned services. Next slide, please. Okay. So as I just referred to, this is the diagram for the process map. So as part of the citywide LCS, we developed this process map, which includes the 5 main aspects of the delivery pathway for the NHS Diabetes Prevention Programme rollout in Brighton and Hove. So you have the 5 aspects, which include the nurse, the administrator, the patient, the health check, and the so from this process map, as you can see, once patients were identified using a practice on the clinical systems which identified potentially eligible people for the diabetes prevention programme, if eligible, they were referred straight into being invited for their NHS health checks prior to continuing to any other stage of the diabetes prevention programme. Next slide, please. So in Brighton and Hove, the Diabetes Prevention LCS described 4 key steps in the cluster model rollout and delivery of the diabetes prevention programme. Firstly, the clusters were to identify a lead practice within their cluster who would roll out and deliver the diabetes prevention programme initially themselves as the pilot location for the cluster, and then support other practices to roll it out. Next step was to recruit an administrator in the cluster. So the job of the administrator was to run the queries, to identify the people, send out the standardized letters, refer eligible people to the diabetes prevention program and other local services, and also invite eligible patients in for their NHS health check. So as I've just said, thirdly, the third step was to refer people, if eligible, straight into an NHS health check, and lastly, to refer patients on for the NHS diabetes prevention program. Next slide, please. So this is a checklist which also formed a part of our NHS diabetes prevention LCS. This was obviously provided to all practices to ensure all were aware of the differentiation of eligibility criteria for each aspect of the diabetes prevention program, and also to ensure the consistency of this across each cluster and the citywide rollout in Brighton and Hove. So it prescribes the differentiation between eligibility for Healthier You, the diabetes prevention program, a health check, and also patients that needed to go for a nurse triage because they weren't sure when the administrator run the searches whether they were initially eligible for the program. Next slide, please.
Slide 10.
So also as part of the diabetes prevention rollout, and to ensure consistency across the city, and finally the correct patients were being identified and referred into the programme, searches were created by our Centre of Excellence for both EMIS and System 1. Templates and codes were also created and embedded on the practice system. We piloted the opt-out letter, which you can see on the opposite side of this slide, as a standard letter, and this was also used in several other areas now and was actually very successful. And basically it gave patients 2 weeks from the date of the letter to allow them time to consider if they wished to opt out of the programme. And if they obviously didn't opt out, then they were referred straight into the National Diabetes Prevention Programme in Brighton and Hove. Next slide, please.
Slide 11.
So finally, just to summarise a few key points from our rollout so far, the lessons learnt and the next step for the NHS Diabetes Programme in Brighton and Hove. Our rollout, we did cluster by cluster, having a champion practice identified in each cluster. So far, we've rolled out in 10 practices across 4 cluster areas, who currently are effectively referring into the diabetes prevention programme. We rolled out 1 cluster at a time for capacity and quality purposes. The process map ensured consistency across the city, and also that the NHS health check programme was a key part, and we have actually seen offers and invites double for the last quarters of our health check reporting, and we see this as a big part down to the diabetes prevention programme, which we've had 490 referrals so far onto the programme. The lessons learnt was we use the champion practices to share knowledge with other clusters and obviously across their clusters for the best practice of the rollout for the diabetes prevention. Each practice needed their own administrator and triage nurse, not per cluster as originally planned. This was due to patient confidentiality and IG purposes. It actually took longer to identify champion practices and also to roll out across the clusters as originally planned, but we didn't obviously want to rush this because we wanted to get quality. And the opt-out letter has been a great success and shared around many other areas that are also rolling out the programme. And finally, just for the next step, so INGIS are to support the rollout of the final 2 clusters. INGIS are to work with the CCG and other practices to get the final 2 clusters up and running across Brighton and Hove. So then all 6 of the clusters will be rolled out and referring into the programme. They also to review the patients still on waiting lists and identify times, dates to offer them for courses and programmes, and finally to work closely with the local services that can support the diabetes programme and the patients to be aware how they can access them appropriately.
That's great, Tori. It's really interesting. Thank you very much for that. It's great to see an example of how the national principles have been implemented, and even better to see how it does appear, as we'd hoped, that getting that alignment right can help increase engagement and activity for the NHS Health Check programme, as well as supporting DPP. So if you can hold questions, we're going to move straight into Liz's presentation. Do make a note of questions because we're going to have plenty of time to ask them at the end of the session. So handing over now to Liz Labram in Surrey, who's going to talk about the approach that they've taken to aligning the 2 programmes.
Hello, thank you everybody. I'll just take you through my slide number 13. We started in 2016 with a health equity audit for our NHS health programme, and the headline outcomes were that we were seeing that the elders were receiving the highest proportion of checks, and that we could do with reaching some more of the residents in deprived areas, and that also the data quality across all of our CCGs, which are 5.5, varied hugely. Aside from that, we also had extreme funding pressures that everybody, I guess, is aware of, but they particularly are affecting Surrey because we already have one of the lowest public health grants. So we had to marshal resources, and as evidence will point that finding those with the highest need will often require more resources. Then later, we've obviously in that year realised that if we prioritise resources and pinpointed populations as needing the health check sooner, then we'd be able to really maximise the opportunity to align the programme with the diabetes prevention rollout. Going to the next slide.
Slide 14.
Thank you. Over the period of the rollout, GP practices had a mixed approach to the take-up, and that was dependent on various different reasons. CCGs had a different approach across Surrey. Some were doing a local enhanced service to help practices, others weren't. They weren't necessarily going to do the same thing across the patch. Early referrals based on practices using approaches as those that they already had on existing registers and pretty much relying on invitation by letter or stratifying by the results of the latest HbA1c code. Alongside that, as a lead for the health checks, I was working on helping practices prioritise on 2 populations, one of those living in areas of deprivation and the others though at high risk of type 2 diabetes. We use the risk assessment tool approach as recommended by NICE. First we went for the Primus route, then we went for acute diabetes, mainly because most of the practices were using EMIS, although not all, or the Leicester Diabetes Prevention Risk Assessment Tool. But after a long summer of agony of realising that most practices couldn't deal with Primus if they have EMIS, that the acute diabetes tool didn't actually bring forward those who were in short-term risk, imminent risk, and most people couldn't handle the tool for identifying people at high risk, mainly because they didn't routinely collect two pieces of data: ethnicity and first step relative having got diabetes. So we pragmatically advised all practices to search for an HbA1c result in the last 18 months or 2 years that was in the non-diabetic hyperglycemic range. I think on to next slide, 15. Was also trying to work on aligning the diabetes prevention program with our other health check providers, and that would be the pharmacies who in our area are able to use the data collection template provided by Farm Outcomes. The template is built to include the best practice trigger for HbA1c, and will be, as soon as we can, working with Ingeus and the developers of Farm Outcomes to make it an easy referral process using the correct pathway and paperwork for our pharmacies to be able to, or other outreach providers who use Farm Outcomes to be able to make a referral. But one thing that we are reliant on is the, with this route, is that the results from the Farm Outcomes data collection tool are sent back safely to the GP practices, but it takes a lot of work to actually find whether the GP practices are routinely adding that data back onto the patient record, and therefore having the data available to them to find who's available or who's eligible for the NHS health check, or no, for the diabetes prevention. So in a roundup, it's been a lot of lessons learnt. We're still working with practices to improve their data and to make sure that there's less variation. We'll be working with them through an audit using a new template that we have for AMOS with our NHS health check. That's pretty much a roundup. I could give more detail, but I really wanted to concentrate on being a roundup, and then if other people had questions that we could go into more detail at that point.
That's great, Liz. I think what we decided when we were planning this webinar is exactly as Liz has said, to kind of give a little taster of a few different approaches, which I often think can be more useful than having in-depth on one. But as Liz has said, please do keep any questions in mind. As Liz has just said, it's another good example of how things have been really well aligned. Great to see the use of a health equity audit to inform that process. And as Liz has said, lots of learning, but various things still to think through. So it'd be great when we get to the question and answers if people have got ideas or suggestions around any of the kind of challenges Liz has noted, then we can pick that up then. So in the meantime, hold your questions again, and we will move on to Stephen Pinnell, Health Improvement Principal in Oxfordshire, who is going to talk about the approach that they've taken. Stephen.
Good morning, Aru. Thank you, Nikki. So yeah, I'm here to talk a little bit about what we've done in Oxfordshire around quality assuring the diabetes filter. For information, we were part of the second wave in NDPP, and we were in partnership with Buckinghamshire on our referral pathway. So we started in April 2017. Next slide, please, slide 17. So I appreciate that the way in which NDPP the referral pathways have been established across England probably varies somewhat. And in Oxfordshire, Buckinghamshire, the CCG are leading on this with our input. So from a perspective of control, we've looked at this and kind of indicated that we only have partial control on that referral pathway as the CCG are leading on it. And as such, a lot of the large focus in the early stages, in the short term, I guess, since April, has been about the retrospective searches, and rather than opportunistic referral pathways through things such as the NHS Health Check programme. But I'm confident that as the NDPP evolves locally, that once the retrospective search is all being done, that actually the opportunistic referral pathways will come into their own. So what we looked at from our perspective then as the commissioners in the local authority was actually what do we control of? And what we obviously have control of is that NHS Health Check programme. So what we had to do then is ensure that our service specifications for the NHS Health Check programme really adheres closely to the latest Public Health England guidelines and reflects on the role of the diabetes filter. And for those of you who are aware, there's obviously a couple of options you can take. So Oxfordshire currently are using the old version of the diabetes filter, which is the based on their BMI or blood pressure. Next slide, please. Slide 18. So what we did, we included in our tendering process, we added some metrics and levers which were related specifically to the compliance of that filter. So you'll see in the slide there that there's a screenshot of this. And this is the one very specific to the risk assessment and the compliance. And we added a threshold of what we thought was achievable of 99%. And effectively what we could do then is indicate some contractual levers to if that wasn't achieved or a provider wasn't achieving that threshold, that we could trigger some formal review of that. Next slide, please. Slide 19. But before we did that, obviously before we considered having any contractual metric from the health check program, we also had to ensure then there was a pragmatic way and actually could we monitor it and could we review this on a regular basis. So what we did, we have a performance dashboard, which is there, maybe quite small to see, but that basically provides the provider of the health check locally a real overview of how they're performing, and it provides metrics such as their activity levels, uptake, etc., etc. But what we did is we added to this dashboard recently their performance around the diabetes filter and their compliance. And I've highlighted an example here where a practice that had done in 2016-17 had done 267 NHS health checks. Of those, 72 of the patients were eligible based on the either their BMI or blood pressure. They were eligible for a blood glucose test. And good news on this practice specifically was that 71 of those 72 received that. So the percentage was just under 99%. The bad news is that Oxfordshire average for the year was 75.9%. So it kind of indicates that there are quite a few GP providers, who are our main provider of health check, who aren't adhering to the compliance for the diabetes filter. So there potentially are patients who are coming through the health check, having their risk assessment done, are obese and or have high blood pressure, but aren't having a blood glucose test delivered. And that's something that we as the health check commissioner can control. Next slide, please. Slide 20, sorry. So one way we looked to address this locally was through quality assurance. So we do audits annually. We refer to them as support visits, whereas we go out to our service providers and monitor them against the national program standards that were launched in 2014 and I believe are currently being reviewed. And specifically, standards 3 and 8 have a reference to the diabetes filter. Next slide, please. So using the program standards, we locally developed a quality assurance tool, and the screenshot here you'll see is from the 16-17 version. And the aim of this is to provide both commissioners but also the service provider an objective measure of the quality of the service they provide, and that's across the whole NHS health check pathway. And what this enables us to do is highlight areas of good practice, but also areas of improvement. So every GP practice that then participates in this process, we get some really good feedback and we develop a tailored action plan with some recommendations on how they want to improve on the quality of the service. And obviously, based on standards 3 and 8, we will get some really good feedback on their ability to adhere to the diabetes filter. And the interesting thing I think here is actually what it does. It has you're having a conversation with providers about quality and not quantity, and you'd be surprised how that's been welcomed by service providers rather than saying you must do more health checks, you must improve uptake, etc. We've changed the narrative a little bit, and it's been very welcome to have a discussion actually the quality of the service being provided. So the In summary, really, what we've done is this is not the only means, but the main means in which we're looking to improve the compliance of the diabetes filter in Oxfordshire is through auditing practices annually, but also monitoring that quarterly through a performance dashboard. And what we hope to see is that compliance, which is, say, for 16-17 was just over 75%, to increase. And what we would do through that then is we will maximise the NHS Health Check programme as an opportunistic referral pathway into NDPP. And that's where I conclude. Many thanks.
Excellent, thank you, Stephen. It's another really good example, but a very different kind of approach, looking at something slightly different. I'm sure that the QA, quality assurance approach that you've taken generally for health checks is of interest to people who are health check commissioners and providers in itself. But great how you've been able to use that to support and ensure alignment in relation to the filter and the blood glucose testing, because I know that it came up in a number of areas in the demonstrator science. I think Bromley, the one who presented previously on a webinar about the issue of maximising referrals for ensuring the filter and blood glucose testing are actually being done. So another really good example. Before we move on to questions, we've got a kind of the next slide. You brought that up. Thank you, Eleanor. Nikki from the Clinical Network and I are going to run through these. I'm just going to go through the first couple of points, and then Nikki will go through the rest, and then we'll have time for question and answers. Just general points really from me. The alignment principles, I hope that this webinar has highlighted how they have been really useful in terms of supporting people to think through the alignment issues. But it has to be said that I think they probably, in some ways, they ask more questions than they answer. The national team, the National Diabetes Prevention team, were clear that local pathways are for local determination, but we did all agree that having these broad principles is a useful way to start asking questions that can make you think through some of the final detail. So it's nothing set in stone, but hopefully they will help others and are helping others to think through and chunk down all the kind of alignment issues. But it's always going to be that the kind of local models of delivery and the local context determines what's important. So Surrey talked about obviously how they'd use a health equity audit, and that's helped them think through how they aligned things. East Sussex, again, we've got a lot of early implementers in the area, and one of the things that was important to them, because they're doing a large-scale NHS workplace programme, was to work with Ingeus, again, same provider as the others, to ensure direct referral pathway from them. So there's all sorts of different issues that will come up depending on the priorities and the context of the local area. I'm going to hand over for the next 4 bullets that Nikki's going to run through. Okay, over to you, Nikki.
Thank you. Yes, I was asked what other elements might enhance referrals, not just to NDPP, but to the most appropriate programme for the person involved. And just standing a little bit from afar, these are the observations I made. I think in terms of commissioning health checks, we know some areas are unable, for whatever reason, to commission blood testing as well following a filter. And I think the fact that the HbA1c is a key factor in referring a person into the NDPP, I would ask those who are commissioning for health checks to consider definitely including those 2 elements within the service specification filter on the HbA1c test, so a person can be referred directly into the appropriate programme. Secondly, again, direct referral pathways. We know that third-party providers don't always have access to the minimum data set required to send a patient into NDPP, particularly things like the NHS number and other bits of data. However, we know from our work with Ingeus that they're very happy to develop a modified data set that will enable direct referrals, because I have heard in other areas that people who've had health checks sometimes have to go back to the GP to be referred into NDPP, and clearly that's annoying for patients and extra work for GP practices. So please do work with providers to work through these direct referral pathways. We haven't been able to automatically code people who've been referred into NDPP via a health check. We'd like to be able to do that because we'd like to know what proportion of people are coming in through that referral source. Again, there's no national code for that or national guidance, and that's something we have to consider locally. But I think finally, in the early days, I think most places running NDPP are looking at the GP NDH registers. Once those have been reviewed and people signposted into NDPP, we're then moving on to relying on opportunistic referrals, and that I think really enhances the role even further of the health check. So continual engagement with your health check providers to raise their awareness and understanding how to refer into the programme is important. Slide 23, please. This is really just a point of information. Those of you who keep up with the QOF may be aware that there are potentially 3 brand new QOF indicators around NDPP, which, if agreed all round, may be implemented by 19 or 20. The reason for the reason they haven't been implemented any earlier is that clearly we haven't got national coverage yet of NDPP. We also know that those CCGs have provided incentives to GPs for referring into the programme. We have a much higher referral rate. So I think those of us who are working very closely with NDPP would be overjoyed to see these indicators in the 2019 or 20 QOF, because I think our referrals would just go off the scale. And that's me. Thank you very much.
Great, thank you, Nikki. That's really helpful and particularly useful, as you say, to kind of look ahead to what we hope will be useful levers in the QOF going forward. That is the end of the presentations. We will have some time for question and answers shortly,